Dear students, welcome to the third online lecture of clinical pharmacy. This is your course lecturer, Yasser Abbasi. In this lecture we will discuss background of guidelines for pharmacy practices and clinical practice guidelines. At the end of this lecture we will see a simple clinical example to understand clinical practice guidelines. The guidelines available for clinical pharmacy can be categorized as those applied to clinical pharmacy services and profession and those that are utilized by a clinical pharmacist in making of decisions in drug therapy management. The latter are termed as Clinical Practice Guidelines or CGP. The practice of clinical pharmacy continues to evolve with the changing needs and demands of contemporary healthcare. These standards are applicable to the delivery of clinical pharmacy services across all healthcare settings. They describe the activities delivered by pharmacists for patients to minimize the risks associated with the use of medicines and to optimize the use of medicines. Comprehensive and accountable clinical pharmacy services are an essential component of contemporary healthcare. Ideally, every health service organization will have resources to provide all clinical pharmacy activities to every patient based on their needs. For example, American College of Clinical Pharmacy, ACCP, has devised standards of practice for clinical pharmacists. This guideline sets forth ACCP's expectations for clinical pharmacists within the United States and countries around the world where clinical pharmacy is emerging. It is also intended to serve as a reference for those designing and assessing clinical pharmacy education and training programs. In addition to articulating the clinical pharmacist's process of care and documentation, the 8 standards are given in this guideline to address the clinical pharmacist's involvement in collaborative, team-based practice and privileging, professional development and maintenance of competence, professionalism and ethics, research and scholarship, and other professional responsibilities. The standards define for the public, health professionals, and policymakers what they can and should expect of clinical pharmacists. The other example is American Society of Health System Pharmacists, ASHP, which devises policy positions and guidelines for the pharmacists that are involved in health system. Some example of guidelines provided by ASHP include emergency medicine pharmacist services, pharmacist involvement in HIV care, pharmacy services in solid organ transplantation, and pharmacist's role in immunization. Another example is the Society of Hospital Pharmacists of Australia, SHPA, which have also generated standards of practice for clinical pharmacy services. These standards include medication reconciliation, assessment of current medication management, clinical review, therapeutic drug monitoring and adverse drug reaction management, contributing to the medication management plan, providing medicines information, facilitating continuity of medication management on discharge or transfer, participating in interdisciplinary ward rounds and meetings, training and education, participating in research, and quality improvement activities. Similarly, various other health associations or pharmacists associations or authorities in respective countries have developed guidelines for their practices according to their healthcare environment and patients' populations. In our country, As we have mentioned earlier, the clinical pharmacy is in transition phase, therefore, like many other countries, we could follow guidelines developed by ACCP and by authorities from other developed countries. The CGPs are systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical conditions. For example, American Heart Association has provided guideline for the management of patients with atrial fibrillation. American College of Cardiologists has generated guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults. Other examples include American Diabetes Association's Standards of Medical Care in Diabetes, General Recommendations on Immunization, Recommendations of the Advisory Committee on Immunization Practices, Center for Disease Control's Advisory Committee for Immunization Practices, and American College of Rheumatology Guidelines for Management of Gout. These were the examples among many. These CGPs have authorization for the diagnosis and also provide authority for therapeutic treatments for the respective diseases. Therefore, a clinical pharmacist always refers to these CGPs for recommendations about optimizing patient care. Before we review one guideline from each category briefly, let's first answer that what are these guidelines? Standards of practice are the how-to of the discipline or clinical specialty. They include clinical policy statements, standards of practice, standard operating procedures, clinical practice protocols, and clinical procedures. Policy statements clarify scope and authority related to a specific activity by defining who can do what activity, with what level of supervision, and when. Policy may be stated at multiple levels. For instance, a state board of nursing may define the role of nurses in medication administration by saying which practitioners can dispense medications and what aspects of the medication process can be delegated. This statement may be refined and clarified at the institutional level in a policy on medication administration. Most other practice standards include documents that describe how a process is done, including the principles governing performance and specific psychomotor steps to be taken. Although they may be developed in a general form at the level of a specialty organization, practice standards usually are tailored to the detailed requirements of an individual organization. Practice standards for clinical research include not only the processes for clinical care that may be provided but also the processes for activities related to the other four dimensions in the practice: human subjects protection, research coordination and continuity management, study management, and contributing to the science. 6. Good clinical practices are another good example of practice standards that apply specifically to clinical research. For example, ACCP states that accredited residency training or equivalent post-licensure experience is required for entry into direct patient care practice. Board certification is also required once the clinical pharmacist meets the eligibility criteria specified by the Board of Pharmacy Specialties. Because clinical pharmacists are practitioners who provide comprehensive medication management and related care for patients in all healthcare settings. They are licensed pharmacists with specialized advanced education and training who possess the clinical competencies necessary to practice in team-based, direct patient care environments. In our country, a pharmacist can start his clinical pharmacy career as trainee clinical pharmacist in various hospitals across the country, after completing his or her basic degree of PharmD. Clinical pharmacists work in collaboration with other providers to deliver comprehensive medication management that optimizes patient outcomes. Care is coordinated among providers and across systems of care as patients transition in and out of various settings. The clinical pharmacist's process of care comprises the patient assessment, evaluation of medication therapy, development and implementation of a plan of care, and follow-up evaluation and medication monitoring. The clinical pharmacist assesses medication-related needs by reviewing the medical record using a problem-oriented framework, for example, interpreting and analyzing subjective and objective information, to determine the clinical status of the patient. Subjective data are information from the patient's point of view, symptoms, including feelings, perceptions, and concerns obtained through interviews. Objective data are observable and measurable data, signs, obtained through observation, physical examination, and laboratory and diagnostic testing. Patient assessment by clinical pharmacist also involves meeting with the patient, caregivers to obtain and document a complete medication history to identify all of the patient's current medications, including regimens and administration routes, medication taking behaviors, adherence, allergies, and attitudes and experiences with medication therapy, obtaining, organizing, and interpreting patient data, and prioritizing patient problems and medication-related needs. In evaluation of medication therapy, the clinical pharmacist identifies strategies to optimize medication therapy mainly by evaluating the effectiveness, safety, and affordability of each medication. There are few more steps involved in evaluation of medication therapy. Please review them from the given document on HUMS. Then, the clinical pharmacist develops and implements, collaboratively with the patient and his/her healthcare providers, a plan for optimizing medication therapy. As we have discussed in previous lecture, that medication optimization involves identification and prevention of medication problems followed by providing a drug therapy that is expected not to be associated with previously identified medication-related problem. The types of medication-related problem have been also discussed in lecture number 2. The follow-up evaluation and medication monitoring is necessary to determine the effectiveness of the plan of care. Here, the clinical pharmacist keeps a continuous watch to see whether the things are going as expected or otherwise. For each new patient, a member of the pharmacy team will compile a medication history from electronic records, from the family, the patient, community physicians or pharmacies, and document that in the electronic medical record or patient file. Clinical pharmacist will then reconcile that list to determine medication-related causes of admission such as non-adherence or overdose and provide advice on which medications to order to avoid withdrawal reactions or other adverse events. A clinical pharmacist should document and review medication history, which should include a brief summary of the patient's past medication, list of all current medications, and a listing of medication-related allergies and any adverse drug events that may affect prescribing and monitoring or preclude the future use of a medication. The clinical pharmacists work with other health professionals as members of the healthcare team to provide high-quality, coordinated, patient-centered care. The clinical pharmacist always believes in an integrated team approach towards maximizing the medication outcomes. Please take note that this is not like that clinical pharmacist acts like an inspector to detect and highlight the errors in patient management, such as medication errors, drug interactions, improper dosages, irrational medication use. But a clinical pharmacist prevents all such errors, being a part of a healthcare team and not as a sole authority. The ACCP expects clinical pharmacists to maintain competence in clinical problem-solving, judgment, and decision-making, communication and education, medical information evaluation and management, management of patient populations, and a broad range of therapeutic knowledge domains. A key factor in professional and competence development is the continual learning of new knowledge and the enhancement of critical thinking and problem-solving skills through practice. Repetition is essential in the development of practice skills, and thus the average levels of performance of Doctor of Pharmacy and residency program outcomes vary depending upon the amount of patient care practice included in the program. Upon entry into the profession, pharmacy graduates are novices at managing pharmacotherapy. Entry-level pharmacy graduates usually gain some clinical pharmacy practice experience during their educational programs. This experience prepares them for entry into the profession, but not as fully competent clinical pharmacists. Pharmacy graduates are often able to competently perform basic clinical activities such as routine patient counseling, provision of drug information, and targeted drug monitoring, but are not competent at providing more complex clinical services. Through continued clinical and additional learning opportunities, they become proficient clinicians and eventually experts in a field of practice. In summary, clinical pharmacists develop proficiency through formal training and practice experience. The ACCP directs clinical pharmacists to always place a trust between them and patients. The commitment of the clinical pharmacist is to act in the best interest of individual patients and patient populations, within the context of legal and ethical parameters. Similarly, there are multiple guidelines for the services of clinical pharmacy, which we might refer while studying relevant subjects. Let's now discuss clinical practice guidelines. Clinical practice guidelines or evidence-based clinical practice guidelines are systematically developed statements to assist practitioner and patient decisions about healthcare for specific circumstances. The use of clinical practice guidelines, CPGs, for the medication management of patients with a wide variety of disease states has been common practice in healthcare settings for decades. CPGs are defined by the U.S. Agency for Healthcare Research and Quality as systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical conditions. They can define or recommend specific diagnostic, treatment, or prevention approaches, and are based on evidence from a systematic review of the published literature on a given disease or disorder. The extensive spectrum of clinical concerns covered by these types of guidelines includes diagnostic tests that are most appropriate in a given situation, fracture prevention measures for postmenopausal patients with osteoporosis, or informing the decision regarding use of surgical procedures versus other treatments for life-threatening conditions such as prostate cancer, to name a few. Best current practice uses relevant findings from well-designed, systematic, randomized clinical trials to identify care options that are supported by evidence-based recommendations. Evidence-based treatment is the current phrase in vogue to describe best practices. A somewhat related concept that is also widely used is comparative effectiveness, defined as a type of research that compares how different treatments, tests, or procedures for specific conditions have worked for others. Clinical practice guidelines are developed by a variety of groups and organizations including federal and state government, professional societies and associations, managed care organizations, third-party payers, quality assurance organizations, and utilization review groups. The purpose of the guidelines, development methods used, format of the documents, and the strategies for implementation vary widely. Considering the potential for clinical practice guidelines to influence thousands to millions of decisions on medical interventions, it is incumbent on all healthcare practitioners to be thoroughly familiar with criteria to judge the validity of guidelines, and be skilled in determining their appropriate application. Development and implementation of clinical practice guidelines have many characteristics in common with traditional activities performed by drug information practitioners, such as evaluation of new drugs for formulary consideration, medication use evaluation, and quality improvement. Many of the skills required for guideline development are required of drug information practitioners, including clear, specific definition of clinical questions, literature search and evaluation, epidemiology, biostatistics, clinical expertise, writing, editing, formatting, and education. Drug information practitioners benefit from the use of clinical practice guidelines as information resources for their work, and based on their skills are logical professionals to participate in guideline development and implementation. Other pharmacists also find clinical practice guidelines to be useful in their practices. The primary attraction for all healthcare practitioners in properly developed, valid practice guidelines is that they provide a concise summary of current best evidence on what works and what does not when considering specific healthcare interventions. New information and new technology in healthcare are developed at a rapid pace. It is very difficult for individual practitioners to systematically evaluate the benefits and risks of all new technology, including new medications. By presenting a summary of best evidence, guidelines assist the practitioner in decision-making for specific patients and also facilitate discussion of care options most consistent with individual patient needs and preferences. Guidelines may also enhance provider communication and continuity of care, especially when decisions are made by multiple providers in different care settings. Evidence-based medicine, EBM, is a philosophy of practice and an approach to decision-making in the clinical care of patients. It is defined as conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. The practice of EBM refers to integrating individual clinical expertise with the best available external clinical evidence from systematic research. EBM is often mistaken for, or reduced to, just one of its several components, critical appraisal of the literature. However, EBM requires both clinical expertise and an intimate knowledge of the individual patient's situation, beliefs, priorities, and values to be useful. External evidence must be used to inform, but not replace, individual clinical expertise. It is clinical expertise that determines if the external evidence may be applied to the individual patient and, if so, how it should be used in decision-making by the patient and the healthcare provider. The development and application of clinical practice guidelines is one of the tools used in EBM. By clinical expertise, we mean the ability to use our clinical skills and past experience to rapidly identify each patient's unique health state and diagnosis, his or her individual risks and benefits of potential interventions/exposures/diagnostic tests, and his or her personal values and expectations. Moreover, clinical expertise is required to integrate evidence with patient values and circumstances. The complete practice of EBM or evidence-based practice, that is, EBP, comprises 5 steps. Step 1 is converting the need for information about prevention, diagnosis, prognosis, therapy, causation, etc., into an answerable question. Step 2 is tracking down the best evidence with which to answer that question. The third step is to critically appraising that evidence for its validity, closeness to the truth, impact, size of the effect, and applicability, usefulness in our clinical practice. This is followed by integrating the critical appraisal with our clinical expertise and with our patient's unique biology, values, and circumstances. Final step is evaluating our effectiveness and efficiency in executing steps 1 to 4 and seeking ways to improve them both for next time. Inquiries in this format take into account patient population of interest, P, intervention or area of interest, I, comparison intervention or group, C, outcome, O, and time, T. The PICA format provides an efficient framework for searching electronic databases, one designed to retrieve only those articles relevant to the clinical question. Using the case scenario on rapid response teams as an example, the way to frame a question about whether use of such teams would result in positive outcomes would be, in acute care hospitals, how does having a rapid response team compared with not having a response team affect the number of cardiac arrests during a 3-month period? The step 2 is to search for the best evidence. The search for evidence to inform clinical practice is tremendously streamlined when questions are asked in PICA format. If the nurse in the rapid response scenario had simply typed "What is the impact of having a rapid response team?" into the search field of the database, the result would have been hundreds of abstracts, most of them irrelevant. Using the Pika format helps to identify keywords or phrases that, when entered successively and then combined, expedite the location of relevant articles in massive research databases such as Medline or CINAHL. For the Pika question on rapid response teams, the first key phrase to be entered into the database would be acute care hospitals, a common subject that will most likely result in thousands of citations and abstracts. The second term to be searched would be rapid response team, followed by cardiac arrests and the remaining terms in the Pika question. The last step of the search is to combine the results of the searches for each of the terms. This method narrows the results to articles pertinent to the clinical question, often resulting in fewer than 20. It also helps to set limits on the final search, such as human subjects or English, to eliminate animal studies or articles in foreign languages. The third step for evidence-based practice is to critically appraise the evidence. Once articles are selected for review, they must be rapidly appraised to determine which are most relevant, valid, reliable, and applicable to the clinical question. These studies are the keeper studies. One reason clinicians worry that they don't have time to implement EBP is that many have been taught a laborious critiquing process, including the use of numerous questions designed to reveal every element of a study. Rapid critical appraisal uses 3 important questions to evaluate a study's worth. Are the results of the study valid? This question of study validity centers on whether the research methods are rigorous enough to render findings as close to the truth as possible. For example, did the researchers randomly assign subjects to treatment or control groups and ensure that they shared key characteristics prior to treatment? Were valid and reliable instruments used to measure key outcomes? What are the results and are they important? For intervention studies, this question of study reliability addresses whether the intervention worked, its impact on outcomes, and the likelihood of obtaining similar results in the clinician's own practice settings. For qualitative studies, this includes assessing whether the research approach fits the purpose of the study, along with evaluating other aspects of the research such as whether the results can be confirmed. Will the results help me care for my patients? This question of study applicability covers clinical considerations such as whether subjects in the study are similar to one's own patients, whether benefits outweigh risks, feasibility and cost-effectiveness, and patient values and preferences. After appraising each study, the next step is to synthesize the studies to determine if they come to similar conclusions, thus supporting an EBM decision or change. The fourth step is to integrate the evidence with clinical expertise and patient preferences and values. Research evidence alone is not sufficient to justify a change in practice. Clinical expertise, based on patient assessments, laboratory data, and data from outcomes management programs, as well as patients' preferences and values, are important components of EBP. There is no magic formula for how to weigh each of these elements. Implementation of EBP is highly influenced by institutional and clinical variables. For example, say there's a strong body of evidence showing reduced incidence of depression in burn patients if they receive 8 sessions of cognitive behavioral therapy prior to hospital discharge. You want your patients to have this therapy, and so do they. But budget constraints at your hospital prevent hiring a therapist to offer the treatment. This resource deficit hinders implementation of EBP. The fifth step of EBP is to evaluate the outcomes of the practice decisions or changes based on evidence. After implementing EBP, it's important to monitor and evaluate any changes in outcomes so that positive effects can be supported and negative ones remedied. Just because an intervention was effective in a rigorously controlled trial doesn't mean it will work exactly the same way in the clinical setting. Monitoring the effect of an EBP change on healthcare quality and outcomes can help clinicians spot flaws in implementation and identify more precisely which patients are most likely to benefit. When results differ from those reported in the research literature, monitoring can help determine why. Improving a patient's quality of life through a direct, responsible provision of medication-related care for the purpose of achieving definite outcomes is the cornerstone of pharmaceutical care. Therefore, responsibility for critically evaluating CPGs that specifically focus on medication-related treatment options can fall on the shoulders of pharmacy practitioners. Adopting explicit, systematic methods for reviewing well-collected evidence and then developing practice guidelines is an important strategy for reducing the opportunities for bias, whether the source of that bias might be intellectual and professional preconceptions, financial interests, or something else. Rigorously developed CPGs have the potential to greatly reduce the chances of patient harm, but CPGs are only one option for improving the quality of patient care. Therefore, they should be critically evaluated by an expert review board before being implemented. Moreover, that process should be repeated periodically to take into account contemporary developments and advances in therapeutic knowledge and understanding. There is a fine line between treating individual patients based solely on the categorically appropriate CPG and deviating from this accepted practice because such a treatment recommendation could be wrong for that patient's specific situation. The development of CPGs is based in large part on the notion that they will optimize patient care and improve the quality of health care. However, given the scope of the millions of patient scenarios that practitioners deal with every day, it is impossible and unrealistic to assume that one will always be able to comply with an accepted CPG or protocol that applies to the patient. Deviations from CPGs must be carefully considered, thoroughly documented, and then explained to the patient to avoid any inkling of unjustified deviation from standard practice, or even negligence. It may be a good recommendation to seek corroboration from a colleague before deviating from agreed-upon CPGs. In contemporary society, professional behavior and decision-making can unfortunately be heavily influenced by the concern for potential malpractice claims. This could deter clinicians from deviating from CPGs when appropriate because of a desire to follow a strict, overly cautious treatment plan. Conversely, in instances where the CPG has the potential to be viewed as lax and not adequately protective of patients, practitioners may be open to allegations of inadequate attention to care of the patient by failing to recommend an optimal treatment that differed from the CPG. Discussion about the practice of EBM naturally engenders negative and positive reactions from clinicians. Some of the criticisms focus on misunderstandings and misperceptions of EBM, such as the concerns that it ignores patient values and preferences and promotes a cookbook approach. Evidence, whether strong or weak, is never sufficient to make clinical decisions. Individual values and preferences must balance this evidence to achieve optimal shared decision-making and highlight that the practice of EBM is not a one-size-fits-all approach. Other critics have expressed concerns that EBM will be hijacked by managers to promote cost-cutting. However, it is not an effective cost-cutting tool because providing evidence-based care directed toward maximizing patients' quality of life often increases the costs of their care and raises the ire of some health economists. From the legal perspective, CPGs can be a sword that cuts both ways. Compliance with recommendations in a CPG when treating a patient may well provide a legal defense should it be alleged that the practitioner performed in a substandard manner. Alternatively, deviating from the recommendations in a CPG may increase potential liability exposure by arming the injured patient with expert guidelines to support his or her position. Clinical guidelines are normative standards and could be used as a tool to indicate customary care. They could be used as a tool for assessment of questionable decision-making or conduct. Guidelines may be consulted by courts because they provide information about standards justified in relation to sound scientific and professional evidence rather than mere custom. Some commentators believe CPGs will define the requisite standard of care for treatment and have a major impact on medical liability litigation. Although CPGs cannot alone establish the applicable standard of due care under the circumstances, they can serve to buttress or reinforce expert testimony. Such guidelines may serve as a source of apposite information of probative value, provided they are the product of a recognized professional body, and prove to bear no relation to a body with the potential conflict of interest. Whether CPGs are used defensively or offensively, critical evaluation of the relevance and applicability of the CPG to the situation at hand is the sine qua non for establishing their relevance. Appropriate prescribing of medications is often a pivotal issue in medical negligence claims. In some instances, both the prescriber and the pharmacist will be taken to task for alleged shortcomings when discharging their professional responsibilities. As we have sufficiently discussed standard of practice and clinical practice guidelines, let's see a very simple example to understand the role of CGP both for a prescriber and a pharmacist. Mr. X has visited your clinic today. When he came last time, doctor asked him to get his HbA1c tested. His report says that his HbA1c is 7.1%, which is not normal. Based on other signs and symptoms, the doctor diagnoses Mr. X as diabetes type 2 patient. Doctor wants to initiate a combination therapy in this patient and asks your opinion. What will be your opinion? I assume that you can select any two medicines from this list based on their few advantages, safety, and price according to economic condition of Mr. X. You can also provide detailed information of many antihyperglycemic agents in this list and let the doctor decide for Mr. X. If I am that clinical pharmacist and I assume myself as undergraduate PharmD student who is in this clinic for a clerkship, I would have done same. But, if there is a senior or trained clinical pharmacist available in clinic, instead of just looking into a table of antihyperglycemic drugs, opening a pharma guide that lists various drugs of same class together, or referring mere Google search, he would refer to clinical practice guideline. Suppose that based on our current knowledge we decided combination of metformin and glimepiride. Now let's see what guidelines suggest about this case. This is glycemic control algorithm by American Association of Clinical Endocrinologists. This algorithm states if newly diagnosed patient has HbA1c levels below 7.5, then the patient should be started with monotherapy. Notice that lifestyle therapy is recommended for newly diagnosed patients with all ranges of HbA1c. Therefore, as a clinical pharmacist we will assist the doctor to educate the patient about lifestyle modifications. The lifestyle therapy includes healthful eating, sufficient physical activity, sufficient sleep, avoidance of tobacco products, limited alcohol consumption and stress reduction. Based on HbA1c values, some guidelines only recommend lifestyle modification for 3 months before starting any medication therapy. This is particularly beneficial for prediabetes patients. In case of drug therapy, you can see that according to HbA1c value of Mr. X, we should start the patient with monotherapy. You can see the green bars below each drug. These bars represent level of recommendations for each drug. And if you read the description in this guideline, you will find that metformin is recommended as initial therapy for all patients unless it is contraindicated or not tolerated. If Mr. X reports the typical problems with metformin, then we can switch him to another single agent from monotherapy options. This algorithm further states that monotherapy has to be continued for 3 months with lifestyle modification. If Mr. X achieves glucose control, he should be continued with same therapy and re-evaluated every 3 months. When the glycemic control is not optimal, the therapy plan is gradually moved to dual and triple therapies accordingly. I hope that the concept of guidelines is clear now. You should consult many of these guidelines while studying disease modules. The soft copies of these slides are available on HULMS. You can reach me on given email. In next lecture, we will study clinical literature evaluation. That's all. Stay blessed.